Happy New Year. Welcome. Happy 2021. Great to see you all here today. Thanks for joining. Thanks for tuning in. I'm Rob Tatro, President and Founder of CMV Canada and the Canadian CMV Foundation. I am excited and thrilled today. We've got a fantastic presentation, something that really touches on something that we obviously have a deep passion for. It has to do with practices for screening and how inconsistent we are with respect to screening across North America, and specifically this research focused on the US. Before I bring them in, the presenters, I'll take a sec here to thank our sponsors. You are watching the CMV Live series. I do want to thank our sponsors, CMV Canada. We also have Merck, the National CMV Foundation. We have NCHAM as well. So wonderful sponsors. We can't do this without you guys. So thank you for sponsoring. As a reminder, the CMV Live series is a series that has a targeted focus as a build up to Ottawa 2021, which is the, what is it called again? The Public Health and Policy, CMV Public Health and Policy Conference. I'm co-chair of that conference with Jess Dunn, Dr. Jessica Dunn, and Dr. Soren Gant. That's happening this summer in late August. Hopefully, if all goes well with vaccination and whatever else, in August in the wonderful, wonderful city of Ottawa. If you've never been, make an effort to come. It's our capital city, phenomenal city. It's so beautiful. We got our parliament there, which is our effective government. It's wonderful canal city. It's got all these markets, beautiful city, tons to do. You guys should come. All right, so enough about Ottawa 2021 and enough about me. Let's bring in our two presenters. I'll bring them in right now. Megan and Kate, thank you so much for joining us today, guys. So Dr. Megan Pesch, Development Behavioral Pediatrician, originally from Canada, BC, now living in Michigan. You've completed your medical training, medical school, residency, master's in clinical research at the University of Michigan. The really, really neat thing is you're a pediatrician, and yet you're the mother of a perfect and adorable 2-year-old with congenital CMV, and that has shaped her research, her clinical program, and she's now focused really, really on universal CMV screening. You and I have that in common, Megan. My focus is getting universal screening, and if you don't know, we have a bill on the slate in Manitoba, my home province, to get universal screening passed here, and you know what's happening in Ontario. So you and I, we're on the same page for that. Thank you for all your work, and welcome, Megan.
Thank you. Great to be here.
All right, good to have you. And Kate Wilson, originally from Maryland, but we're not going to hold that against her. We still like her a ton. She calls Michigan home. Previously received her master's biotechnology from Johns Hopkins. That was before entering medical school. Completed her pediatric residency, University of Louisville. It was there that she kind of developed her interest in CMV. Her primary research interests lie in exploring the screening practices for congenital CMV, which is so critical. So I'm so thankful to have you both here, because screening, I have a t-shirt that I just got made, start screening, and I wear it all the time now because I want people to know how important screening is for CMV. So thank you so much for both being here today. I'm excited to have you here. I'm excited to hear your presentation. So I will now step out and I'll come back and we'll answer questions. If you're watching on Facebook, on YouTube, wherever you're watching, Instagram or Twitter or whatever, please press subscribe, press like, share the video, share the feed with your friends and family. This is important, and we're thrilled to have you here. Ladies, I will leave the proverbial microphone to you, and I will step out.
Okay. Thank you so much. All right, we're just getting our slides loaded here. Perfect. Okay, so Dr. Wilson and I hail from the University of Michigan here in Ann Arbor, Michigan. So our presentation today is going to be an overview of our provider testing practices for congenital CMV, which, as it turns out, are consistently inconsistent. And just briefly to go over our conflicts of interest, Dr. Wilson has no conflicts to disclose. I serve on the board of directors of the National CMV Foundation here in the US. It's an unpaid position, and they had nothing to do with this presentation or this research. So just an overview for the sake of completeness. We all know congenital CMV is all too prevalent. So about 0.5% of births in North America. And of those, 10 to 15% are symptomatic, and the remainder are asymptomatic. Pet peeve of mine, that terminology. And we do also know that there are some significant risks for long-term sequelae like sensory neural hearing loss and, of course, neurodevelopmental delays. And again, just to briefly go over this, the symptomatology or the presentation of CMV is so wide-ranging. And we know that most kids actually don't have any visible signs or symptoms at birth. If you go looking for them, you might find some lab or imaging findings. And then there are the minority that present with kind of a smattering of really subtle, often signs, which makes it tricky to pick up. And the sensory neural hearing loss that comes with CMV is like, it's amorphous. So 30% of kids about with a symptomatic CMV will experience hearing loss, and about 10%, but maybe up to 25% of those asymptomatic kids. And the hearing loss doesn't look like one thing either. So there isn't like a characteristic pattern of CMV hearing loss. It can be unilateral or bilateral, different frequencies. It can occur, not at birth, but then at age 5, you can have sudden onset. It could be progressively worsening. It can fluctuate. It can improve. So even just looking at the hearing loss, you can't really pick out CMV from other causes of hearing loss. So just to kind of take an overview of CMV screening practices. So why would we screen for this? Well, we know that early detection opens up opportunities for early intervention. And that can be medication, antivirals, but it can also be like monitoring of hearing, amplification of sound, getting kids into early intervention, monitoring their development. There's a whole host of other things, but we can't do those things unless we detect these babies. And there are different modalities for screening. The gold standard right now is viral isolation, so PCR of urine or saliva, but there are other ways to do it as well. And it's really essential that we screen these babies before they're 21 days of age. And that's because it gets really tricky to figure out what's a congenital infection versus, a postnatal infection after that point. So the different screening approaches, so provider suspicion is basically like, does a doctor or healthcare provider look at a kid and say, could that be congenital CMV? Based on the symptoms or clinical concerns. Targeted screening means that you would screen all infants that present with a certain presentation. Most often we do targeted hearing screening. So babies who fail their newborn hearing screening get a CMV test. And that's kind of like a systematic program. And then universal, which I'm biased towards, is screening all babies for this. And so we are going to discuss our screening practices at Michigan Medicine, aka the University of Michigan hospital system, which underwent this rebranding for some reason a few years ago. So technically it is Michigan Medicine. And so our objective was really to analyze provider practices used to screen for CMV in our U.S. quaternary care pediatric hospital. So this hospital, we have around 3,800 infants born each year, but there are no current screening practice guidelines. And so just to kind of breeze over our methods so we can really dig into the results, this was a single center retrospective medical chart review over a 6-year period. So we looked through the beginning of 2014 all the way through the end of 2019. And we looked at the charts of every single infant under the age of 30 days who had a CMV test ordered. And then we looked at the demographics of those infants, what test was ordered, the indications the ordering physician put, of course, the result, and then if there were any signs or symptoms that were present, in the physical exam or lab findings. So here are our results from a 6-year period. So get ready. Over a total of 6 years, 274 babies were tested for CMV. That is a testing rate of 0.001% of infants born at our institution. And of those, 179 were testing for congenital CMV, so that's 65%. But 35%, which is a pretty sizable proportion, were actually looking for postnatal CMV. So specifically, these were babies, and we have a pretty solid complex care program. So a lot of kids who come in for a cardiac transplant workup, or who might have like a really severe upper respiratory infection and end up being hospitalized. So that's kind of the postnatal infection. So even of those 274, only 65% of those were actually ordered to look for congenital CMV. So of those 179, there were 13 positive cases, so 7.3% over that 6-year period. So it's a median case of 1 per year. It changes per year, so 1 to 5. And then if we look at the detection rate, like how are we doing in terms of detecting CMV in our birth population? So we detected 12. There were 13 positive, but 1 was transferred in from an outside hospital, and then we retested. So I don't think we can take credit for picking up that baby. So it is a detection rate of 0.0005%, which is 1,000-fold less than we know the actual true prevalence of congenital CMV is. So if we had, hypothetically, implemented universal screening, we should be detecting 1,000 times more babies, but we missed them. And just briefly, we looked at the infant demographics of all the babies that were screened and the babies that we found to be positive. And, really, they most were born at the hospital. Versus being transferred in, say, to like a NICU or critical care unit. Moms were about 28 years old. They had on average 2 kids. Most of the babies that were tested were premature, although the babies that ended up being positive, most were term. They had similar gestational age and weight, similar proportion of gender distribution, as well as a race, ethnicity, and just over 50% of each group was on public insurance. So just briefly to look at our screening modalities, meaning like what tests did we order? The royal we, not me. The what test was ordered. So in here, you'll see in the orange, we have the quantitative PCR, and that can be of urine or blood. In kind of the more reddish orange, we have a viral culture, and then that teal turquoise is as an IgG or IgM. So in 2014, we were pretty split. Still, viral culture seemed to be pretty popular, but quantitative PCR was increasing in popularity. IgG, IgM was also ordered, which, frankly, is not very helpful since maternal antibodies are passed on to infants. So that doesn't really tell you much of anything. Thankfully, it looks like that has been phased out for the most part. And then over the years, quantitative PCR has really become what we do at the University of Michigan. And here, if you look at screening by unit, meaning like which unit of the hospital system was ordering the testing, by and large, it's the NICU that's ordering our testing. So these are the sick, complicated babies, which makes people think of CMV. We do have the PCTU, which is our cardiac intensive care unit, as well as our pediatric intensive care unit. 16% were ordered by the newborn nursery. However, that is by and large where these babies are born. Like 95% of the babies born at University of Michigan would be born and cared for on the newborn nursery. And then pediatrics, that gray, that is, some pediatricians order them as outpatient. So here in the US, unlike Canada, pediatricians provide outpatient kind of general care. And then some babies were on the general pediatrics floor and had it ordered. By and large, it's the ICU babies that are having the tests ordered. And then here we'll just look briefly at the trends. So who was ordering the testing over the course of the years? And so you'll see the top line, the orange line, is the NICU, and they have been the strong leaders for the most part, ordering about 70% of the tests, and then declining a little bit in 2018 and 19. But really, because this is an overall percentage of tests, that is really the decrease is really because there has been an increase in ordering of tests by the newborn nursery down there in the red line, and also our outpatient and general pediatricians, the gray line.
Okay, so now we're going to transition to symptomatology. So when we looked at all of the babies that had been screened for congenital CMV and their associated symptoms that were documented in the physical exam, we noted that the most common symptom shared was jaundice, followed by SGA or IUGR, so intrauterine growth restriction, and then microcephaly and thrombocytopenia. We then learned that there were a total of 25 different screening indications documented by providers. We then categorized the number of indications that prompted screening. So, for example, if a provider wrote for a CMV test to be ordered based on SGA, that would be a single indication. Or if they listed SGA and microcephaly, that would be 2 indications. And then 3 would be SGA plus microcephaly plus failed hearing screen. We then were showing you the single indications that were documented. And as you can see, most would kind of fall under the criteria that has been previously defined by those in the field for symptomatic CMV. For example, abnormal imaging, physical exam findings such as petechiae or hepatomegaly. Some other additional findings would be a sepsis evaluation. And then just to clarify quickly before we move on to the next slide, so SGA in this context is really just defined as weight less than the 10th percentile by the growth curves respected for prematurity or term. And then symmetric SGA refers to being small across the board. So for weight, head, circumference, and length. So when we look at the screening indications across all of the units, across all 6 years, which is all the 25 indications included, we see that the most common screening indication is symmetric SGA. And then the other ones that seem to be common would be abnormal head imaging, and then sepsis evaluations, direct hyperbilirubinemia, and then SGA, and one other indication. When we look at the screening trends across the years, there were 16 different screening indications documented in 2014. And then it seemed to become a little bit less in 2015 before it uptrended consistently into 2019 with 18 documented different screening indications. And the dotted line just shows the linear uptrend of our own screening trends. When we look at the screening indications by NICU providers, you can note that there are several different screening indications noted on the y-axis of this graph. And then the most common is symmetric SGA by large. When we look at the newborn nursery, so less screening indications, and their most common indication to order a test is the positive maternal test and symmetric SGA. And then in the pediatrics units, including inpatient and outpatient, so by far less number of screening indications prompting testing. And unfortunately, there's no dominant screening indication in this group. And so it is other, however, other is all encompassing. And so we did not call that a most common indication. But I would like to note that there are 2 failed hearing tests. So this is the unit that is screening based on that sole indication. When we look at indications that actually resulted in a positive CMV result, so the NICU had 3, and if you recall, their most common indication was symmetric SGA, and there was no positive hits in the NICU. For the newborn nursery, their most common was positive maternal testing and symmetric SGA, and as you can see, they had 3 that were positive for positive maternal testing. And then in the pediatrics units, where there was no most common screening indication, they had 3 results for various reasons. And so in summary, at the Michigan health system, we had 13 positive congenital CMV cases that were identified by screening 179 patients over 6 years. And once again, just to reiterate, that is a miserable detection rate of 0.005%. And so way under the prevalence of this viral disease in our population. And on average, it's about 1 case a year. The majority of the cases are are ordered by the newborn intensive care unit. And however, there is an uptrend since 2019 in the newborn nursery and pediatrics. And we primarily screen by urine PCR now, but we are hoping to move that forward to saliva. And the most frequent symptoms associated with these patients are jaundice, SGA, microcephaly, and thrombocytopenia. In terms of screening indications, there were 25 different indications listed by providers that prompted screening. And the number of indications can range by year from anywhere from 10 to 18. The majority of screening was prompted by a single indication. Those that listed a secondary indication, the most common was the addition of thrombocytopenia. The most common screening indication overall is symmetric SGA. And the most common screening indication that was actually associated with a positive CMV result was positive maternal testing. And just to reiterate that the number of times the most common screening indication by unit yielded a result. So in the NICU, that was 0. So symmetric SGA did not return any positive results. In the newborn nursery, positive maternal testing returned 2 results out of 5 that were tested. And then also in the newborn nursery, symmetric SGA returned 1 out of 5 that were tested. And so in conclusion, we at Michigan Medicine are very infrequently testing for CMV across the board. So in the newborn nursery, in the newborn ICU, in our cardiac ICU, and in our inpatient, outpatient pediatric clinics, we are very inconsistent with screening based on our quote screening practice of provider suspicion alone, since we have no implemented screening practice guideline in place. We have learned that provider suspicion varies greatly on providers' awareness and recognition of CMV. And so as it was previously mentioned, so by and large, the NICU orders a lot of our screening. And so it's potentially assumed that these babies are so symptomatic that that's how they're being screened in that unit. Our screening practices vary not only by year, but by unit and by provider. And so we are just so consistent at being inconsistent in CMV screening. And relying on provider suspicion alone leads to missed congenital CMV diagnoses. And so a majority of these cases are likely missed in the neonatal period. And as you all have learned, that by our low detection rate and our infrequent screening and inconsistent screening practices, we are missing a majority of our cases and likely a majority of our asymptomatic cases. And so implementing a systematic screening guideline would only improve our providers' recognition, which would then improve our diagnosis and then management there forward. And so these are our references, and that concludes our presentation. We'd like to thank you all for listening to our research, and we welcome any questions.
Just fantastic, fantastic stuff. I'm blown away by a couple numbers, but the 1 out of 1,000 that we're catching, it just hurts me right here because I think of how lucky we were that we got caught, that my son got treated, and I think of all the other kids. That's why we're doing this. For the other 999 that are being missed consistently, we now have data. Like, we knew this, and I think there's been studies done in Canada with respect to the amount of babies that we're catching, but to actually see the numbers on a presentation like this, it actually hurts. It actually hurts me to see this. And it also motivates me. The argument that people tell me all the time is, don't worry, Rob, we're catching most of them. We're catching most of them. Bullshit. You're not catching any of them. This is absurd. It's so ridiculous to be sitting here and to be trying to pat ourselves on the back as a healthcare system, anyways, in Canada, to be saying, you know what, our pediatricians are good at identifying this, and they're good. They're not catching any of them. And like, the other thing is the newborn hearing screen, 27, I think was the number. 27 of the reasons that were referred was because of newborn hearing screen. This is, it just blows my mind because we know that it's the #1 cause of non-hereditary hearing loss is CMV. I keep using this example all the time, but if you have an infection and you knew that the #1 cause of infection was X, wouldn't you test for X? Wouldn't that be the first thing you would do? You would test for X to just, take it out, and then you would know that it's not that. Sorry, I'm getting heated here, but
no, I feel you for sure. And like, it's so like, as a pediatrician myself, I learned next to nothing about CMV. So I'm always like, and I certainly I'm certain that I missed my fair share of cases. And I think I say that almost like in defense of these physicians, because we need some systematic way to screen these babies, because no matter where you go to medical school or how well trained you are, this disease just is just really hard to catch. So I think a lot of people end up being like, oh, like, why aren't the doctors blah, blah, blah. But no, it's CMV that we should be mad at. And so we need to create the system to be smarter than the disease.
Yeah, and to be clear, Dr. Pesch, you nailed it on the head there. I'm not upset at the doctors because it's a system that fails for them, right? Mm-hmm. They're charged with 10 million things and they got to take care of us. We could easily eliminate this one hurdle and this one obstacle facing every pediatrician by just having universal screening. Like and never mind targeted screening. We know that 2% of babies or whatever are failing their newborn hearing screen, which on 22,000 births would be, 440 babies fail their newborn hearing screen, probably a lot more, but let's say at a minimum 2%. Yeah. And now we know that only 27 of those got referred for a CMV screen. That's ridiculous. So there needs to be 5 years ago, there needs to be a targeted screening in place at every hospital. And now today there needs to be universal screening so that pediatricians like yourself don't have to, it's not an added burden for you. And we have a system in place and we know it's cost effective. Mm-hmm. We know it's cost effective based on the research done by Dr. Soren Gant, which was published. So, we know it's cost effective. We know the parents want it. And, you've presented research here that proves that we're not catching any of them. Yeah. There's a question here. I'll stop my rant here. And there's a question here from, you guys know Kathleen Muldoon.
Hi, Kathleen.
She's watching. She's got some good questions. She's saying, interesting that screening is coming mostly from the NICU. Are these kids who have complications, symptoms due to CMV or other conditions needing more neonatal support? And she's asking about data to compare with, the data that compares well with baby nurseries, I believe is what she's asking.
The Well Baby Nursery, yeah.
So
do you want to tackle that?
So by and large in the NICU, there's been only really one child who was transferred in for management of congenital CMV from an outside hospital. And so the kids that are being screened in the newborn intensive care unit are children that have symptoms that would be concerning for CMV. For example, SGA and or microcephaly. Kids that have additional indications like thrombocytopenia, transaminitis, abnormal head imaging would then prompt screening. And so it's largely a screening as opposed to known diagnoses and management. And then, go ahead.
Sorry, the NICU babies are sick. They are sick, it's not just like your term small baby that's hanging out in the NICU, they need extra support to stay alive. So they're sicker. And so I think that the level of suspicion is probably higher. And maybe, it's the bias too of thinking about the baby with CMV being the, blueberry muffin baby, which we know most of them aren't.
I think
and which we have not seen.
Yeah, sorry to interrupt. That's a huge takeaway. And I did also wrote it down here in my notes while you guys were presenting. The misconception that the only babies that have CMV, like my son, Megan, you talked about is it your son or your daughter? Sorry.
My daughter, yeah.
Your daughter. I mean, I don't know everyone's situations, but I've met a lot of CMV parents. And there are some, blueberry babies for sure. But there's a whole bunch that are regular kids and regular looking kids on first perception, and they're not being caught. And the proof is your NICU screens are like 70% of them, right? So I get that there's that mentality, but we really have to stir the pot everywhere else. There's another question here. Rachel Crane Smith is asking a question. She's really interested in learning more about asymmetric SGA. Just for viewers, SGA, small gestational age, correct? Yeah, and long-term prognosis in babies. For example, weight and height in normal percentile, very high, and head size is the low end of the normal range. I think she's asking, so if there's specific microcephaly, is this a microcephaly question?
Yeah, I think if you have kind of like borderline microcephaly, but are still like long and have some heft to you when you're born. Yeah, so I think what we know about those babies is, that the head circumference, has kind of been our biggest predictor of developmental outcomes. But I use air quotes because the literature on developmental outcomes is so not great. So like, for instance, they'll say, oh, a poor developmental outcome could be anything from hearing loss, which might be amplified by a hearing aid, or it could be, intellectual disability. But those poor outcomes are kind of lumped into one. So like that is basically meaningless for families. So kids that are born with, the smaller head circumference, in general, Rachel here, she's saying borderline, but not diagnosed. 7%, girl, that's great. I think that's well within normal. And so I think just like a smaller head size, I wouldn't put too much necessarily in that, but I do think following head growth, is important to kind of see where, that the brain is growing and developing, as microcephaly can be a proxy for that. But the limited studies that we have do show that kids who truly have microcephaly do end up, it's a prognostic, it is a predictor of poorer outcomes, not 100%. And what poorer outcomes mean is like very non-specific.
Very interesting. Very interesting. I know that there's, Rachel's also adding here that it makes her feel good for long-term prognosis. I know only time will tell.
Mm-hmm, mm-hmm.
Absolutely. Yeah, my son was 99.9 percentile for size, for height, for weight, and for head. Massive baby. Looked like a powder puff, what is it? The marshmallow man or whatever. Like rolled, multiple rolls on each arm kind of thing. Just a huge baby. And I remember the doctor telling us, doesn't have CMV. Don't worry about it. Doesn't have CMV because it's only with babies with only small babies. You're fine. We'll test it anyways. You're fine. Tested positive on the urine. Okay, well, he doesn't have CMV. It must be, we'll do the blood. Tested positive on the blood. Well, he doesn't have CMV. We'll do a spinal tap. Did the spinal tap. And then they're like, guess he's got CMV. So, I mean, Dr. Pollock's a beauty. I love him. And it was a different time. It was 13 years ago, right? So it was, what we knew was different, but let's remember to we need to identify more babies is all I'm getting at here. And your research shows this. I imagine you're going to be presenting this in Ottawa, 2021.
Sure hope so.
Yes. All right. Well, thank you so much. Thanks for your time. I know there's Dr. Muldoon is asking me spinal tap. Yes. I swear to God that happened. My wife almost passed out. She could not be in the room. She had to leave. This poor baby had been through so much. But anyways, he's fine now. He's doing great. He's playing the piano. Started playing the piano through COVID, and he's doing great. But yeah, it was a rough time back then. I know they wouldn't do that now, right? They'd get their urine, maybe blood, but like that's good.
No tap.
It's been really fun, really interactive. I love this research. I love what you guys have put together. I think I think we need this kind of work to be done. So I'm thankful that you guys spent the time. I'm thankful that you guys have devoted a big portion of your life to CMV research. CMV Canada is thankful. Also, I'll take a sec here to thank our sponsors, Merck, NCHAM, CMV, National CMV Foundation, our wonderful brothers, sisters south of the border, and the Public Health Policy Public Health Policy Conference on CMV, which is happening in Ottawa 2021. Don't miss it. Take a sec to subscribe to our videos, press like, share it on Twitter, Instagram, Facebook. Follow us on Facebook, on Instagram, and on Twitter. We got these really neat masks that we're selling right now on our website. Check it out. They got the see-through mouth, so that if your child is someone with hearing impairment, they can lip read through the mask. Really, really neat. They're branded with CMV Canada. We're also going to have some shirts up for sale on our website soon. It's going to say, I support Bill 214. Bill 214 is on the legislative docket to be second reading in March or in April this year. It's happening, folks. So we do need support for that. If you're thinking of writing, if you're a Manitoban and you're watching and you want to help, we do need you to reach out to your MLA, to your representative, to start drafting letters. We could help you with that. Dr. Pesch, Dr. Wilson, thank you so much for your time today. We'll stop it there, and we will see you guys in 2 weeks, viewers, in 2 weeks. I need to remember this. Yes, engaging children in active learning at an early age, 2 weeks today. We have 4 or 5 more presentations in anticipation of ramp up of Ottawa 2021. You guys are fantastic. Thanks for your time, everyone. Yeah. That'll be it for today. You guys have a great day. Stay positive and keep testing negative, guys.